Hello everyone and welcome to Oral Medicine Simplified. I'm Dr. Suman Saeed Siddiqui and in today's session we'll discuss two clinical cases of herpes simplex virus infection. In my previous video, I have already discussed generally about herpes simplex viruses, so if you haven't watched that, I would highly recommend you to watch the video. So our first case is a 30-year-old female housewife, married, who presented with a recurrent painful lesion on her upper lip. The patient told us that before each episode she experienced a slight feverish feeling, then small fluid-filled lesions appeared on her lip actually. She also reported that these lesions recur almost every month and they heal spontaneously within 5 to 7 days. Currently, the lesion had been present for 2 days. On examination, she looked healthy and oriented. On extraoral examination, her face was symmetrical, but on the left side of the upper lip, we noticed a reddish crusted lesion. There were around 5 small vesicles present. Now let me pause here and explain what a vesicle is. So a vesicle is a small fluid-filled blister that is less than 1 centimeter in diameter. I hope you can appreciate this little thing over here. So it looks like a small fluid-filled blister that is less than 1 centimeter in diameter. It is filled with clear fluid. Now, if it is not filled with clear fluid but a purulent or yellow fluid, we won't call it a vesicle. Okay, so the fluid must be clear, which is usually serum or viral exudate. In herpes infections, vesicles appear in clusters, often described as a crop of blisters, as we saw in the previous video, in the previous picture, that the lady has 4 to 5 small blisters over the lip, like here. Okay, so now this thing we won't call a vesicle. We would call this a scab. When the vesicle or the infection reduces over time, these vesicle ruptures and they form a crust or a scab. Okay, this picture was taken from healthline.com and it describes the stages of cold sores very nicely. So I have used their picture to explain further. So in stage 1, the patient might just feel tingling around the mouth, and if it is recurrent, if it is not the first episode, they usually know that the cold sores are coming. Okay, and treating the cold sores during this stage will actually reduce its severity and duration. You may notice there is no lesion present here. It's just a feeling that the patient gets that there is some tingling and now I'm going to get cold sores. So a day or two later, one or more fluid-filled blisters appear on the skin surface, and the area around that blister is usually red and erythematous. So within a few days of appearing, the cold sore will break open. The open sore will be red and shallow. This is how it would look. And eventually at stage 4, the blister will dry out and it will look yellow or brown. And this stage is known as the crusting stage. The final stage is the healing stage. The crusted blister or the scab will fall over and will disappear slowly. So coming back to our patient, on intraoral findings, there were no vesicles or ulcerations present intraorally, and the patient was medically fit. There were no habits that could be associated with the lesion. There was no investigation required in this patient because it looked like a viral infection. It was recurrent. It had a course like a viral infection. So we didn't go for any investigation in this patient. If we were gonna go, we would be going for PCR, but PCR takes up to 4 to 5 days for the report to come back, and that was the actual course of this disease in the patient. Her vesicles and ulcers would disappear after 5 to 7 days. So doing a PCR seemed uh, unnecessary in this patient. And for the treatment, we had discussed options of the treatment previously in our previous video. But for this patient, we just educated the patient that this is a viral infection and infection stays latent in your body. And whenever you are going to get whenever you're going to get any stress, fever, there will be exposure of sunlight. If there is menstrual cycle or a trauma, then these can recur. So we educated her that she should separate her towels and utensils. She was also advised to improve diet in terms of protein and keep the lesion moist. And we also told her that she should start using topical acyclovir gel next time when she starts feeling the tingling, as that would reduce the exposure of other people or getting the infection from her. And then we told her that for pain and fever, she should always take a paracetamol. So overall, this case is a classic example of recurrent herpes labialis, which is also called cold sores or fever blisters. It happens because HSV1 remains latent in the trigeminal ganglion after the primary infection, and whenever the immune system is weakened or the patient faces triggers such as stress, fever, sunlight, menstruation, or trauma, the virus reactivates and causes lesions on the lip. What is important to note is that in recurrent herpes labialis, the lesions are limited to the keratinized mucosa, such as the lip, hard palate, or the attached gingiva. So for the management, we have two options, like symptomatic relief can be given by using petroleum jelly or any anesthetic spray or gel, and paracetamol for the fever and the pain. And for treatment options, we have systemic or topical antivirals. Now we are coming to our second case, which was of a 12-year-old male student who presented with painful eruptions around his lips and inside his mouth for the past 10 days. Now, 10 days is a pretty long time for a viral infection. So we'll discuss this in detail, okay? So his parents reported that before the oral eruptions appeared, he had flu-like symptoms, which included fever, malaise, and sore throat. Afterwards, he developed painful vesicles and ulcers, followed by fever that lasted 3 days. Because of the pain, he was unable to eat or even drink liquids properly. So this led to weakness and dehydration of the patient. So on general examination, the child appeared weak and required support to walk. Saliva was dribbling from the corners of his mouth, and this dribbling of saliva is also called drooling, which happens because the mouth opening is painful. On extraoral examination, we saw multiple vesicles of varying sizes around the lips and the perioral skin. Some vesicles were larger than 1 centimeter and had crusted over. The lips were swollen, tender, and crusted, making it very difficult for him to open his mouth. Now let me explain again. When vesicles rupture, they leave behind shallow, painful ulcers. When many vesicles merge, they form larger, irregular ulcers, which explains why he had such severe pain. As you can see, even his mouth was shut close due to these vesicles, which has crusted around his lips. So it was very painful for him when we tried to open his mouth, but this was day 1, and there were many vesicles. These are vesicles. This is the crusting, and this is the ulcers that basically coalesced together and then formed a crust. So intraoral examination showed inflamed gingiva, a furred tongue, and redness of the tip of the tongue. The furred tongue was because it was painful for him to open the mouth, so he would not clean his mouth properly. The gingiva was swollen and erythematous, and this is why this condition is called herpetic gingivostomatitis. There was no such medical history or drug history associated with this patient, and we could not relate in any personal habits to this. For the lab test, we went for culture and sensitivity, CBC, ESR, serum iron, and TIBC, serum ferritin, and serum electrolytes. His eosinophils and ESR were raised, while iron studies and electrolytes were normal. The swab culture revealed secondary bacterial infection with E. coli growth. Okay, this could occur because of the raw ulcers that are prone to contamination. So it was a secondary infection in this patient. For the treatment, we went all in this patient because the test for the culture and sensitivity came very late. So we started about everything for the symptomatic relief. So he had a furred tongue. We had to start an antifungal syrup. In that we used Fluzy 50 mg per 5 ml syrup. Then for the local relief, we used mouth spray. For the top antiviral, we used SLX ointment for 4 times a day. Then we also used a broad spectrum antibiotic because there were open ulcers which were prone to contamination. We gave the patient infusions of plobide because we needed to hydrate the patient. We also gave him Panadol or paracetamol for the pain and fever. Over the next few days, the patient gradually improved with reduction in pain, swelling, and lesion. This is like a topical ointment is applied over these, but I think you can appreciate that the redness has reduced. The patient can actually open a little bit of his mouth, and by the day 2, the vesicles that were present in these areas had uh, been converted into scabs as well. So this was day 2 for us, but for the patient it was day 12. And for a virus like HSV, the first infection usually lasts for 1 to 2 weeks. 14 days is its time, and but if the patient is immunocompromised, that can go further on. So it can be pushed to 3 weeks as well. But thankfully, this patient came at day 10 towards us, and this was day 12 for the patient. And following the treatment, he gradually showed improvement. Now on day 4, you can see that the scabs that were present over here have also fallen off. And by day 7, the patient felt fine. There was no fever. There was almost no pain in this patient. But unfortunately, this patient didn't show up to us for follow-up, so we could not just get any follow-up picture of this patient, but he was admitted in our department for 7 days. So this is a typical case of primary herpetic gingivostomatitis, which is most common in children. So unlike the recurrent herpes labialis, the primary infection is widespread, and it affects both keratinized and non-keratinized mucosa. The key features that we need to notice are fever and malaise before oral lesions. Then there are painful vesicles and ulcers on the lips, gingiva, tongue, and buccal mucosa. The gingiva can be swollen or bleeding. There can be difficulty in eating. There can be drooling and dehydration. So this condition is usually self-limiting and heals in about 10 to 14 days. But supportive care is very important. Systemic antivirals such as acyclovir can be prescribed if started within the first 3 to 5 days. But unfortunately, this patient reported to us at day 10. But we still started acyclovir in this patient. To summarize, the case 1 showed recurrent herpes labialis in an adult woman with monthly painful lesions lasting less than a week, and case 2 showed primary herpetic gingivostomatitis in a child with systemic symptoms, perioral vesicles, gingival inflammation, and severe pain. The key differences are that in primary HSV, the lesion is widespread. There may be systemic symptoms, and it generally affects children. Whereas in recurrent HSV, there are localized lesions, there are no systemic symptoms, and it is generally in adults, or it recurs in adults. Thank you for watching Oral Medicine Simplified. I hope this session helped you not only understand the cases, but also the basic concepts like what vesicles are, how primary and recurrent herpes differ, and how to manage such patients. Please don't forget to like, share, and subscribe for more simplified oral medicine lectures. See you in the next session. Thank you.